We've been around for over 20, 25 years doing this. And in that time, I've learned don't be the first kid on the block to do something new, because there's a lot of fads in spinal surgery, and they don't always pan out. Just because everybody's doing it doesn't make it the right thing to do or the best thing to do. And I think we should stick with things that are tried and true, things that work for people. We should stick with them, And in my experience, going posteriorly has, we can do an interbody fusion through a TLIF or through a PLIF. And avoid that anterior surgery. There's a lot of complications with anterior surgery, especially in men. There are more complications, but women as well. You generate more scar tissue. You can get vascular injuries. You need an approach surgeon.
You need to organize the approach surgeon and the schedule and everything like that. It's not always so easy.
It's not always so easy, and it's not always beneficial to the patient. And also, you're saving the patient another operation. If you could do it all through one incision, I think that's always a much better way to go.
That's right.
Than doing two incisions and causing. Some people will phase it out. They'll do one operation on one day anteriorly, and then a week later do the second part, or they flip them the same day. It's a lot of surgery. It's a lot
of time, and I think that we can do pretty much everything that we have to do, really less than 3 hours for anything we, really even the most complex things. We try to keep it under that time, and I think that's important. I think that reduces your infection rate. The less time you spend in the operating room, obviously.
You've got to be very efficient in the operating room. Time is money, and you want to do things efficiently, quickly, but most importantly, safely. And so we pride ourselves on the safety aspect. And then another thing that we do, which helps in the healing process, is we use a plastic surgeon. And the plastic surgeon, people ask, why do I need a plastic surgeon when I have spinal instrumentation? And I tell them, well, it's a big operation. And plastic surgeons are really good at handling the soft tissues, and the wound complications are dramatically lower since we started our
they're better at closing the dead space. That's
much better.
That's important. Cinching down that muscle onto the space and closing in a really tight, layered fashion. The risk of an infection really is significantly reduced.
Right. There's risk of infection. There's risk of hematoma. There's risk of wound dehiscence or wound breakdowns or wound openings, and really we've seen that minimally since we started engaging the plastic surgeons.
I think we got to get we got to get our plastic surgeon.
I think we should
talk about how he approaches these things.
Yeah, I think it's a good idea.
We have a lot of opportunities for having.
So we need a neuromonitoring team, and we need a plastic surgeon.
We need a plastic surgeon.
We should probably get the nurses in the operating room to come too, and they can discuss the positioning of the patient and
the nurses
all that's involved
important.
with that. And maybe we should even get some patients to come in one day.
Well, I think we're going to need to, as time goes on, we should definitely get some patients.
We need some guests.
Because otherwise, we could be talking about this and. It's not really a reality unless you see a patient.
Until you see a body.
And we need to also show some films, I think, in the future as well. We'll get that going as well. But we can talk about a lot of different things.
Stay tuned. We have more things in store for you.
So we're still on the subject of fusion and trying to make people feel better about their surgery. I tell them sometimes that that putting in the screws is actually the fun part. That's the easy part of the surgery. That's the part of the surgery that's actually pretty straightforward. It's the decompression is the most important thing because that's usually what brings the person in for their surgery to begin with. Is their symptoms of their leg pain, their leg heaviness or weakness.
I would agree.
If a person has a misalignment and has instability of that misalignment, then obviously the back pain is helped. Tremendously by the screws, and if that person has instability, then you need to use those screws to basically stabilize it. So after the surgery, the patient will have some relief of their back pain as well.
Exactly. And then what we do after the operation, a lot of times, is to even still enhance that fusion more. Is we'll use an electrical stimulator device.
Right. Exactly.
Electrical stimulation, and that actually, believe it or not, promotes fusion as well. It's a hard thing to believe because, when they come into the office and they're fit with this electronic device, it looks like voodoo. Like, really, this electrical device is going to make me feel better? Because you don't really feel it when it's emitting that electricity, and a lot of these devices are only 30 minutes a day. And it's interesting. There's a lot of research done after the Vietnam War where they had a lot of veterans who ended up getting amputations because they had fractures from gunshot wounds that weren't healing and would often lead to an amputation. They had infected wounds. And so the U.S. Army really spent, and the government spent billions of dollars trying to invest and figure out what can we do to get these veterans to heal their fractures and not lose their
They
extremities.
could stop smoking.
Smoking is definitely one thing.
That was one thing, unfortunately.
But if you put an electrical impulse across those
fusion masses
across the bones,
Yep.
you believe it or not, you actually increase the healing of long bone fractures. And so when we do a fusion, it's the same idea, the same technology that's being used for a fracture to heal. So we're actually tricking the body when we do a fusion that you have a broken bone. And so your body naturally releases BMP, but we're adding exogenous BMP, genetically engineered BMP to put in that area to cause the fracture to heal or cause that fusion to heal much quicker. And it really truly works. And then by adding the electrostimulation afterwards, our fusion rates are well over 90% now.
How does the cells align with that current that's passed through for the actual stimulator?
By putting electrical charge, your body generates an electrical charge when there's a fracture.
Right.
And so it's creating a stronger form of electrical current that induces more BMP to be released, and it basically causes a spiral, which will then lead to fracture healing much quicker.
The devices that are used after the surgery are more like they look like vests, basically.
They look like a back brace almost.
Right. So
it's a coil.
In the old days, we used to insert these batteries underneath the skin, and then you take these two wires that emanate from the battery and put them below where underneath
over the fusion mass,
where you put the bone. You put the bone on top of the wires, and then after the bone has fused in the future, months later,
you take them out.
You take out the battery and you leave the wires in, basically underneath where the bone has grown on top of the wires. So you can't remove the wires at that point because they're part of the bone mass at that point.
So people I think have fallen away from doing the implantable bone stimulators because it's another operation.
It's another operation for them.
There's metal left. There's a foreign body that's left inside the patient's body, and these external ones are decent enough that I think I don't think it's necessary to do the implantable.
The only reason why it was good is because of compliance issues. You knew that if it's in there, the person's not going to wear their device.
That's very true. That's very true in a lot of aspects of spine, but we rely on compliance. Do people take their medication when they're given a prescription? Do people put on the stimulator when they're asked to put it on? Do people wear a brace when they're told to put a brace on? A lot of the literature on scoliosis is that kids, you tell them to wear the brace for 23 hours a day, hoping they'll wear it for 12 hours a day. And if you only tell them 12 hours, they wear it even less than that. So it's human compliance is a major issue in everything in medicine, but especially bone stimulation.
We can only take it so far, obviously. But that's why you have to really, when you do a fusion, you got to do it right from the beginning, and you have to make sure the bone that you put in is clean of soft tissue, and when you stimulate the bone that you put the bone mass onto, these transverse processes, you got to make sure you have all the soft tissue removed. You're meticulous. The technique is very important in what we do. I think that we got it down.
Yeah, so, and when you lay the bone, you're not just laying down on raw bone. You're basically taking that bone, you're drilling into that bone, so you create a bleeding surface.
Bleeding bone is what stimulates the fusion.
That's right. You want that bone marrow to be exposed and giving those factors and those cells, those osteocytes that are going to cause the fusion mass to take place.
When you come back in a patient in the future, let's say the patient has a problem at another segment and we have to remove the hardware, we'll go in after several years where that person has had that hardware and the bone has grown over that hardware, where you literally, in order to remove that hardware, to replace it or to actually add another segment of hardware, the bone, you have to chisel out the bone just to get to the hardware.
Sometimes it's very difficult.
So I always tell patients also,
sometimes it's not worth it.
Well, that's sometimes not worth it because it's
create more harm.
It's create more harm. But I tell patients that just think of the screws as just becoming part of your spine, it's just becoming part of your body basically at that point after the fusion.
Now, there have been some reports that if you use BMP, there's a worry that it can grow into the canal. And I really have never seen that.
I've never seen that either because we really keep it as a barrier, essentially. We don't go over go basically towards the canal we keep it on the sides, on the other side of the joints, and I think that's the way you have to do it. And you have to, at the end of the surgery, you got to make sure everything is just tucked in on the side.
Right.
But I've never seen that either, really, where a sheet of bone has grown over.
It really shouldn't, because there's no substrate for it to grow into.
Right. I think that's why the scaffolding is so essential. That's really what keeps it going at that, where in the position you want it to be in.
Yeah. When you've done a complete laminectomy, there really is no bone left over that's going to attract.
People are always wondering, how come you're allowed to remove the bone and not put it back? People ask that question all the time as well.
Well, we kind of do put it back, but in a different way.
Right.
We take the bone that's been removed, we morselize it in that special blender, and then we put in the lateral gutters with that BMP a lot of the time, and so it's been recycled. We're like the Native American of days of old. They don't let any part of the animal go to waste. We don't let any part of the human body go to waste that we can reuse.
And it's okay. I always tell patients it's okay to leave that gap because, first of all, there are gaps to begin with between each segment. We're just making the gaps a little bigger. But then I tell them after the surgery, there are layers upon layers of tissue that go over to protect it as well. So honestly, unless somebody shoots you with an arrow right at that spot, I don't think people have any fear of that defect being there in that respect. So tons of scar tissue forms.
So no archery for your post-spine patients.
You just want to avoid archery ranges after spinal fusion, basically.
No deer hunting.
No deer hunting, no.
Yeah. Well, that's
or at least wear your protective brace,